Yes, I am so excited. Finally, I'm getting to meet Dr. Stephanie Freeman in person. Dr. Stephanie, I speak in coffee mugs and t-shirts, and I have a t-shirt for you tonight that I want to show. I don't know if I can see, if you can see it, but it says, "Cute enough to stop your heart, skilled enough to restart it."
Oh, I love it.
And that is for you because you are just so smart and so talented and so adorable. And I'm so happy you're
Thank
here.
you.
Dr. Stephanie Freeman, my friend, is a board certified pulmonary critical care doctor, and she works full time as a locum tenens doctor. And we're going to tell you what that means, but I'd like you to introduce yourself and tell us where you're from and what you do and how you got to where you are now.
Yes. Well, thank you for having me, Dr. Alexis. I am Dr. Stephanie Freeman. I'm not a pulmonologist. I'm a critical care physician. I'm double board certified, and I am from the Deep South. I like to tell everybody I am a true Southerner, born and raised in Tuscaloosa, Alabama. Went to the University of Alabama, so the accent is real. Now I live in Houston, Texas, so I am a Southern girl at heart. Did my medical school training at UAB. I did internal medicine at Wake Forest. I did a geriatrics fellowship at Wake Forest, and then I did my critical care fellowship at the University of Pittsburgh. And so I've been an intensivist, which is a physician who specializes in critical care medicine. I've been a board certified intensivist since 2006. And what I do is I travel all over the country doing what we call locum tenens, which is Latin for placeholder. And what that means is people who work as locums doctors work on an as needed basis to fill in place of. So if there is a need, if there is a shortage of physicians, if somebody wants to go out on vacation and they just need some short-term coverage, they call us in. And I've been doing that for 13 years, traveling all over the country, taking care of patients all over the country. And it is something that I absolutely love. So I'm so excited to be here with you today.
I imagine that you have been incredibly busy in the COVID era because your expertise and your experience and your knowledge base is one of the specialties that we really need and depend upon as we are taking care of patients with COVID. How has that been in the last year and a half?
Oh my God, it has absolutely been insane. It has been something that I don't think anybody would have ever thought that it was gonna get this bad. We had no idea. I used to think that flu season every year was bad, and I used to warn people. I'm like, listen, y'all don't know this, but every year from November to April, the healthcare system comes this close to collapsing due to influenza. I was like, y'all have no idea how close we come every single year. And then COVID came and destroyed everything.
And
And I
blew those markers out of the water.
blew those markers out of the water. It
Yeah.
has been absolutely insane.
We have pretty thick skin, especially, I'm an I'm a family medicine hospitalist, but I work in the, general medical wards and in the ICU. And so you and I you especially see the life and death. We really see the worst of it. And I think we have a pretty thick skin. I think we're pretty used to, giving families bad news, and we're used to holding people's hands as they die. And for me, and I don't know about you, but has just taken that emotional toll to such an extent that I was never prepared for, even in my craziest nightmares. And I really thought that I was, and I wasn't ready for this emotionally, that this level of pain and suffering and death. It's just been really, really hard emotionally. How are you holding up?
Well, thanks for asking. I'm holding up very well because um, I had to take a step back because I realized that this this was something that was going to be ongoing for years.
Mm.
I realized that it was my responsibility to care for myself physically, mentally, emotionally, spiritually, because other people weren't going to do that.
Yeah.
I realized that the people that we work for do not care about us. I realized that the general public does not care about us. And what I mean by that is because they don't see what we see, they don't heed our warnings. And sometimes it begins to seem like it's falling on deaf ears.
Yeah.
And I'm talking about especially last year when the numbers were going up and healthcare systems were crumbling, and we were opening up field hospitals, and I was getting called every few hours to see if I had any availability to hop on a plane and go staff this field hospital. I don't know where, right?
Yeah.
And that was happening, and the world kept going on as if nothing was wrong. Had people arguing about masks, and now we have people arguing about vaccines. And it's like everything you and I, as a physician, everything we've worked for, everything we've tried to do to keep people healthy, it seemed like nobody cared. And then on top of me traveling to get to some of these places, and last year traveling was hard because the flights were at reduced levels. Hotels were barely empty. There were barely no rental cars. And I would go to these places to work and take care of these critically ill people. There was still a lot of uncertainty. We didn't know what worked. We didn't know what we should do. What one place did was different. Other places did were different. You had to jump through all these hoops to get all these medicines that were experimental. And then for people not to treat you with basic respect and not realizing what we are going through or had to go through, or even what I had to do to get to the job, I just took time off. So last June, I tapped completely out. Like in May, Dr. Alexis, I gave my 30-day notice to all of my assignments.
Good for you.
I'm not doing it. I said, I'm not coming back here. I don't know what I'm going to do, but I'm taking the rest of this time off because I have to heal me. Because the thing that was scary for me was not the emotion that I was feeling. I was scared that I stopped feeling.
Mm.
And I was like, this ain't good. And so,
Wow.
right. And so, how did you deal with this? And you have children that you are terrified for their safety, and you have, I don't know, did you homeschool? Were you your husband, were you, I know you had to be terrified for him if he, as he was going out in the world. How did you, as a working mom who had to virtually school her kids, handle all of this?
Yeah, we were pretty strict with lockdown last year. The kids, our school district, fortunately shut down school, and we did virtual school all year. I kind of just, you know, told them, yeah, we're going to do the work and we're going to try to learn as much as we can on our own on the side, and academically didn't put too much pressure on them because they were going through it too. And
Mm,
we were asking them to behave like it was normal, and it wasn't normal. I think what's been so hard on the whole, on our family and our colleagues and on our, you know, our professional lives, which obviously bleeds into our personal lives, is that this disease has become politicized, and it's we, you know, the ones taking care of the patients, the ones who are seeing it and doing it, like you said, are really, you know, we feel sometimes like our work is being taken for granted. And that's been the hardest part, because my kids know mommy goes to work because there's people out there who need her, and there's people out there who
mhm.
will die without us. That will,
Right.
you know, and that's just the truth. And when you feel like you're going to work and that work is appreciated and that people are doing their part to help you do your job and to keep you safe, because there are only so many of us, that makes the job worth doing. And when suddenly, you're right, when you feel like you're just a piece of the puzzle that is dispendable, disposable, and not really appreciated, especially in this grand and like this scenario that is so significant, it really hurts, and it hurts emotionally, and it hurt our family dynamic because, you start to take your work for granted, and it starts to stress you out, and you become more vulnerable, and you become less patient and less happy, in a job that really meant a lot or means a lot. And last year, we all thought this was like, there was going to come an end to this. And now, as we're seeing, like you said, that where a lot of us are realizing that this is a long-term thing, and that we need to figure out how we want to participate, how we can analyze where we are and what we're doing, and how we're approaching our personal and professional lives and our health and wellness in order to be able to continue in this fight, and not just say, oh, well, when this is over, because clearly it's not going to be over. Yeah. So let's talk about what we came here to talk about. And it all ties in so beautifully, because the people who are most susceptible to any illness, infections, autoimmune conditions, inflammatory conditions, the people who are most susceptible are the people who either have a genetic predisposition or have environmental factors that contribute to making the body vulnerable. And one of those things is stress. And we are living in an era in human history where people are experiencing a tremendous amount of physical and emotional stress. And so I want to talk to you, and that's why we came really today, to talk about how stress contributes to illness, acute and chronic illness, and what we can do to really change how we address and manage our stress in an attempt to prevent acute and chronic long-term illnesses. What I always tell patients is that when I'm trying to teach prevention and I'm trying to teach healthy lifestyle changes, I talk about the ICU all the time. And I give the example of diabetic ketoacidosis, which is a state of extreme high glucose, which makes the patient's blood severely acidotic and causes all kinds of electrolyte abnormalities that could be fatal. We're great at treating it. We can get rid of it in less than 24 hours. But diabetes in a lot of patients is a preventable disease. It is one of the conditions where stress is most definitely a contributing factor. So I talk a lot about how a lot of the things that we see in the ICU are complications from diseases that are potentially preventable. You can't control your genes, but there are a lot of other factors in your life that you can control. Your weight, whether you smoke or not, whether you use toxic substances or not, how you exercise, what you eat, your social emotional connectedness, and your stress levels. So talk to me about how physiologically, how stress leads to potentially acute and chronic illnesses.
Well, you're absolutely right, because I can tell you of the people who, pre-COVID, even with COVID, who ended up in my ICU had medical comorbidities, the diabetes, the high blood pressure, the heart disease, the kidney disease, the liver disease, the strokes, and all of those are preventable. Everything has risk factors that can be prevented. And stress is huge in this country. I recently gave a talk about COVID-19 and also in the Black community. And one of the things I focused on is the social determinants of health, how where we live and the communities we are born into and the environment surrounding those communities with access to healthcare, access to medical insurance, access to healthy foods, access to a good educational system, access to, walking sidewalks and parks. All of those actually are more important in terms of determining your lifespan than other things are, because they all come together to lead to the health issues. So the social determinants of health is the external stressors in your environment that cause the internal stressors, that cause the metabolic derangements that damage your body. So, right, it comes down to stress, social determinants of health, and we in this country don't do a great job in terms of not looking at the what, like I like to call it. I like to say, not, let's not just look at the what, but let's take a broader look and let's look at the why. This person has X, Y, and Z, but why do they have that?
Yeah.
What's going on in their lives that's causing them to experience this in their bodies? What sort of trauma have they had? You know, there was a recent study about the adverse events of childhood that Kaiser did. And it was amazing because it's like, what's the number? 75 or 80% of adults experienced adverse events as children. And there's a direct correlation to the number of adverse events you experience as a child to your health and the health outcomes as an adult. So the data is now beginning to catch up to what a lot of us have intuitively known all along, but now, like you're doing, Dr. Alexis, now we have to have conversations in terms of how can we mitigate those forms of stress, both internal, immediately external, and societal stress that then manifest themselves as illnesses that can lead to a premature death.
I really appreciate how you explain those three different levels of where the stress can be addressed and how disease can arise because of conditions that are internal to your body, genetic, conditions that are immediately around you, and conditions that are broad, more social or economic conditions. When you talk about the ACEs, I get chills when I talk about the ACEs because adverse childhood experiences are independent risk factors for actual diseases like diabetes, cancer, liver disease, even infectious diseases like hepatitis and AIDS. So when what we're saying is when someone has stress in childhood, as their bodies and minds are changing and growing, their body is responding to that stress and is changing. Your genes are changing to the point where you are activating systems in your body that will cause you to express medical diseases as an adult, which is unbelievable. It's just so mind-blowing that something that's like psychological. When we say adverse childhood experiences, we talk about exposure to trauma or abuse as a child, parents who are, either abusive, alcoholic, if you've experienced homelessness as a stress, if you've experienced lack of resources, financial resources, if you've not had food on your table. These are all considered stressors that can change the genetics of a human as they enter into adulthood.
Death of a parent.
Death of,
How many
exactly.
children lost parents this year? And how's
Exactly.
that going to be manifested 30 years from now?
Yeah.
Divorce.
Exactly. And so when we talk about access to resources, we're talking about a bigger issue than like, oh yeah, I can exercise, I can like try to get good sleep. There's a probably minority of people who have the resources to be able to make healthy, meaningful lifestyle changes. Right? I mean, a lot of communities, how are you, if you're working 16 hours a day, 2 jobs, how are you supposed to have the time to, or the money to buy healthy food and the time to cook a healthy meal and sit down with your family? Where is the time to exercise? This is just one example, but there's a minority of people who have the resources to make those meaningful changes, to reduce their stress level, to get good food, to get good sleep. It's like, it's kind of frustrating because it's like, we say these things like everyone can do it.
Right.
Like the playing field is level. Like everyone can just go to Whole Foods and buy a $10 salad for dinner. And that's just not the truth. I think that in especially in, Black and Latino communities, in my patients, for example, I think a lot of people just grow up assuming that they're going to have the same diseases that their parents had.
Mhm.
You know, I'm just going to get high blood pressure. I'm just going to get diabetes. And I'm just going to, that's just part of the process because everyone around them has those conditions, and they're not taught how to take care of themselves. They may not have the resources, the access to the education that they need to teach them how to make healthy lifestyle changes, or the money that they need to do those things. So you can say all the things you want to say, but on the larger picture, the larger scale, what it really comes down to is how do we care for our communities? How do we give our communities really what they need to make those healthy changes? How do we change it from the inside out? Because we're talking about making changes, and there's a whole bunch of people who are listening and want to do that, but don't have the resources to do that.
Absolutely. I mean, you're absolutely right. We take for granted. And I think I did like some informal research, like where I live. I think I have like maybe like 5 grocery stores within a 10-mile radius of my house. So I can go to Kroger, not just any Kroger, I can go to the signature Kroger. And then if I don't want to do that, I can drive 2 blocks and go to the HEB.
Yeah.
And then if I don't want to do that, I can go to the Walmart Supercenter. And then if I don't want to do that, I can go to Sprouts. And then if I want to get really fancy, I can drive 30 minutes and go to Trader Joe's.
Mm-hmm.
But there are a lot of communities, both urban and rural, that are in real food deserts. And if they have a grocery store, the produce section is atrocious. So we do take for granted that people are able to really overcome what I call the social determinants of health on an individual level to make better choices. Choices are limited if your options are non-existent. If you don't have any options, then what choice are you going to make?
Exactly.
And I think the healthcare community is just now beginning to realize that, and we're just now beginning to push for change on a broader level.
Yeah.
But it takes a lot, even especially as physicians, because we're so quick to label somebody as non-adherent.
Yeah.
Oh, they missed dialysis. Well, why did they miss dialysis? Well, they couldn't get a ride. Well, why couldn't they get a ride? Well,
Yeah.
because they live with their daughter, and their daughter got called into work today, and she had to work, and she couldn't miss work because, of course, they live with their daughters. They got to pay the bills, and patient couldn't find it anywhere way else to get to dialysis, so they missed dialysis, and then they come to the ER with the potassium of 8.
Yeah.
And if you're not careful, we could label that person as not adherent. And going back to your example of diabetic ketoacidosis, the number one cause of that is missed insulin. But insulin is expensive. A lot of people don't have health insurance. How are you going to afford it?
Yep.
If you're unhoused, how are you going to store your insulin? Because it has to be refrigerated. So then once again, if we have repeated people who keep coming back and coming back and coming back, it's so easy to label these people as non-adherent. But we have to take a step back and look at their social determinants of health and say, why is it this is their third admission in 3 months? What's going on at home? Do they have a home? Are they unhoused? How were they able to keep their insulin? How are they able to get their insulin? Are they able to get their supplies? So there's just so much of societal stress, economic stress, social stress that plays in to all of this. And then we see it during when people are hospitalized, but it's just so much larger than that.
Yeah. And it's really, it's when you're in the situation, you're just going through your day, you're just trying to get your patients seen.
Mm-hmm.
You're just trying to make sure everybody's tucked in, everybody has what they need in the hospital. They have their medications, they have the medicines that they usually take at home. They have a diet that they are getting their blood work and their IV fluids and you're just kind of going through the motions, trying to make sure that everything is done and taken care of. And when we send our patients home, we send them home and we do what we can from a social work perspective to optimize that discharge plan. But when those resources are limited beyond the hospital, in the home situation, we're essentially, setting patients up for continued failure. And when I say failure, it's a failure of the system, not a failure of the patient. And Dr. Stephanie, we're going to talk about it because I'm 100% pro physician and pro healthcare if we're really talking about caring for people and doing our job to keep people healthy and make people healthy and cure disease. But when we talk about it, a great example I can think of right off the top of my head is that hospitals invest a lot of money in joint replacements. And we spend a lot of money putting new hips in and new knees. And certainly the people who qualify for those procedures need those procedures. But when you look at what food stamps cover, or what's not eligible, what kind of foods are being served in school lunches, if we took some of those dollars that we're using to spend on the quality of life of the people who can afford a knee replacement and put some of those dollars into outreach, which we know works and helps, and funding of real health programs in communities, maybe that person, who is getting a knee replacement, wouldn't need it. Maybe that person will have made lifestyle changes that would have prevented them from getting osteoarthritis or prevented them from being obese and causing their knees to wear down. Maybe that money that is going towards the people who can afford it, who have insurance that makes hospitals a lot of money, if we took some of that money and put it back into the communities, those communities could make better choices and have the resources that they need so that they don't end up in an ICU with a $17,000 bill for an overnight visit for DKA because they don't have a fridge to keep their insulin. It's so big and it's so frustrating when you're not in the day-to-day and you step back and you look at it. That's what we're looking at. That's what we're talking about.
Right. You're absolutely right. And I think it comes down to a fundamental notion is that we in the United States of America are going to have to ask this question: who are we as a country and how do we treat everybody in this country?
Yeah.
And there's a time for rugged individualism and pull yourself up by the bootstraps, but you can't pull yourself up by your bootstraps if you have no boots, or if your boots get taken away from you, or you lose your boots as a result of the fact that just some horrible things happen to you or your community, or your boots get taken. So, rugged individualism has its play, but we have to start looking at things as more of a collective. We need to realize we are our brothers and our sisters keepers. And if the one thing this pandemic has told us that, everybody can be affected. Now, initially it was not affecting certain demographics that had the resources to shelter in place and had the resources to stay at home because they weren't deemed essential workers. It wasn't targeting those people as much. But now, baby, that nobody's staying at home anymore.
Right.
Okay. Everybody has opened back up and we all breathe the same air. And COVID is airborne. So there really is, the sooner we as this country come to realize that we are a collective of people and that what affects one eventually affects all, until we realize that, we're going to continue to have these problems. So I think it's going to take a fundamental shift in the consciousness of this country to say, every human being in the United States of America deserves some basic fundamental human rights, some basic fundamental things so that everybody can do better. So we can all do better.
Yeah. I mean, like we were talking about infection and now we're talking about, consciousness, our social and moral consciousness. And I love how it all ties in, and it pains me how hard it is because we have a problem with universal healthcare in this country. Mm-hmm. We have a problem with immigration and people who are not natural born US citizens taking resources from people who are US born citizens. And we have Europeans who have the mentality of, I contribute to my healthcare system so that my brother, immigrant or not, my neighbor, my cousin, my friend, the guy who drops off my mail can, have a procedure if he needs to. So I don't have the answer. I don't know if you do, but where does that shift come from? How do you communicate to someone that you have to care for other people? You have to care about other people.
That is you nailed it. You nailed it, Dr. Alexis. We have to care for one another. And I don't know who is religious, who is not religious, but the greatest commandment in the Bible that Jesus said is what? To love one another. That is the greatest commandment. Everything else hinges on love, love for one another. And if this pandemic, it is just so ironic that we're having this conversation
Yeah.
in the midst of a pandemic, because of a pandemic whose virus is spread by air. Air. We breathe the same air.
Yeah.
And if it doesn't get any more clearer, the smoke from the wildfires out west is now being seen on the East Coast.
Yeah.
Every year we get a sandstorm. Dust from the Sahara Desert travels thousands of miles to affect our atmosphere, the air we breathe. There is no segregation of air. We breathe the same air. And this pandemic, SARS, is airborne and it's killing us. And until we start caring about everybody simply because we're humans and it's the right thing to do, until we learn this lesson, we're going to stay in this pandemic, and there's going to be another one and another one and another one and another one.
Yeah. Yeah. My dad, always tells me, he and I, neither of us are very religious, but he always talks about the golden rule, which is part of every religion under
Every religion.
do unto others. And you're right, a pandemic that affects every single person, every single culture. I think to myself, and I'm getting a little bit, agitated about it, but you're one person in a short span of a lifetime. You know what I mean? To think that our own individual rights supersede my right to go out and not wear a mask, my right to not wear a vaccine, to get a vaccine, to think that my one life that is meaningful to me and to people around me, on the grand scheme of things on the planet Earth, to think that my one life is so important that I can disregard the other 7 billion people on the planet Earth is, just in my opinion, it's unfathomable. I can't imagine. And I feel that I'm very connected to nature, and I feel that we are being intervened upon, whether it's religious, whether it's some kind of bigger picture, whether it's Mother Earth telling us we have been intervened upon. The earth is screaming at us that we are hurting it. We are hurting each other. And that if we don't fix it, or if we don't change our ways as neighbors, as communities, as a country, the way we interact with other countries on this planet, that it's not going to get better, that we're going to continue to burn, and we're going to continue to transmit viruses, and viruses are going to continue to get angry and mutate, and Mother Nature will always win, because that's the law. Right. So I just think it's naive to think that as one person you can change things, but that's kind of the point of why we're here, why we do what we do, and why we speak beyond the one person who's opposite us in our exam rooms. We speak to the people who are listening, who do care, and who each of us has the ability to impact the communities around us exponentially. And that love and that compassion extends. So that's why we do what we do, right?
That's why we do what we do. I tell everybody, and I think some people sometimes probably think, probably like, you're getting on my nerves, but I said, my job is to keep you healthy and safe. That's my job. For people who've told me, oh my gosh, I would love for you to be my doctor, they think it's a compliment, but it's not. Mm-hmm. Oh my God, I want you to be my doctor, because if I'm your doctor, it means you're critically ill. Yeah. I love you enough to want to work myself out of a job. I would love for critical care medicine to no longer have to exist as a specialty because nobody gets critically ill. I would love that.
Yeah.
Our job as physicians, you know, Hippocrates said it, physician means teacher. We're teachers,
Yeah.
and we're healers too. You know, we're teachers and we're healers, and we're also priests too. In ancient society, physicians had that role. So we are the ones who love.
Mm.
We're working out of love for our patients, and sometimes it comes across as paternalistic, and it comes across as you should do this,
Mhm.
but we really don't want y'all getting sick. We want y'all being healthy.
Yeah.
It's about love, love for our human man, our a fellow man, fellow people.
So we say to each other, consider one another,
Mhm.
be considerate of one another. Think about how your actions affect those around you immediately, those in your community, and those beyond. And to our colleagues who are fighting this battle and others, and who are getting run down and who are not necessarily holding on or holding on but are not doing well, remember why we do it. Just
Mhm.
remember why the 15-year-old or the 8-year-old who said, I'm going to be a doctor, you know, why you did it and why you should continue to do it, because the world needs us, right?
So I also tell other physicians, I have to remind myself of this because this pandemic has taken a huge toll on physicians.
Mm-hmm.
About 400 physicians have died of COVID.
And how many by suicide?
And not by suicide, right? So that's just 400 physicians who have died from
Yeah.
COVID. There have been at least 6 suicides in the last month of physicians, and physicians have one of the highest rates of suicides.
Yeah.
So for my fellow physicians who have had it, who are burnt out, about to get burnt out, I say pause right now and go get some help.
Mm.
I stepped away from this
Yeah.
last June, and I mentioned this earlier in the podcast. I canceled the rest of my assignments for the year, took the entire month off, because the Bible says, physician, heal thyself.
Mm.
We have to heal ourselves. And what does that mean? Does it mean the burden of healing ourselves is placed solely on ourselves as physicians? That means we need to recognize in some ways that we are not well, and
Yeah.
that's okay, and to get the help that we need. And we have to start talking about stress. The stress that's on lives of physicians is unimaginable, especially those physicians who have families and have children and have, you know, economic responsibilities, because a lot of physicians took an economic hit with this pandemic.
Yeah.
We risked our lives going to work, risked our lives not having adequate PPE, risked our jobs by speaking out. Then when all of this was over, some people got rewarded with what? Laid off, furloughed, fired, contracts renegotiated. So it's moral injury on top of moral injury on top of moral injury. Now some economic uncertainty, and physicians need some real help. So I'm telling every physician who is listening that it is okay to take a step back. It is okay to quit your job. Just do it in the appropriate way. It is okay to say, I'm pressing pause. I'm burnt out. I'm taking a sabbatical. I'll be back when I get back. It's okay to do that because I've done it.
I did not expect this conversation where we're like, oh, we'll talk about COVID, we'll talk about stress, to go so deep or mean so much to me as a woman, as a mom, as a wife, and as a physician. And I just really appreciate the chance to talk to you about this in such an honest way. And girl, if my heart stops, I need you there to restart it for me. I want you right by my side to restart it for me, because I know you are so capable and you're so skilled and you're
Phone call
so.
away, or I'm always on Facebook. You know that.
I do. I follow you. I follow your travels. I feel like a stalker sometimes, because I'm like, oh my God, she's in Alaska. Oh my God, she's here. And it sounds like you have found the work-life balance. So to wrap up this conversation that has just filled my soul with so much happiness, I want you to tell our friends, our physician colleagues, where they can access your Locum Summit, where you can help them figure out if the system is getting you down, how to take control back, be able to live a life that you love, do the work that you love without all of the red tape. Let us know.
Right. Thank you so much for that. So, yes, I am a firm believer of locums work, and simply because it gives you back control. Control. Most physicians that I talk to fall out of the love of medicine, not because we don't like clinical medicine, it's because we don't like the bureaucracy and the administration and the politics and the red tape. But once I've been able to show physicians that there's another way, that they can fall back in love with medicine again and do what makes their soul happy, which is to take care of patients and put patients first, you can learn to do that by doing locums. And we're going to talk about that in my Locums Doc Summit. The Locums Doc Summit is a 2-day virtual conference, October 22nd and 23rd. It's virtual. I do a VIP day on October 21st, and we will be bringing in leading industry experts to talk about all aspects of how to get started with locums, how to tweak your locums career, and you'll also find support amongst other physicians who do locums work as well. And as a special offer for those of you physicians who are listening to this podcast who really want to be a part of my Locums Doc Summit, if you purchase your ticket at www.thelocumsdocsummit.com and enter the code Dr. Alexis 20, you will get 20% off the price of the ticket. And I know Dr. Alexis is going to drop the purchasing information and the promotional code as well. But like I said, the Locums Doc Summit, www.thelocumsdocsummit.com, October 22nd and 23rd, virtually.
I think it's incredible what you're offering. The thought, the potential of having control over a career that is not dictated by other people is really, really exciting. And I think it's a beautiful way for us to get our careers back. And so I appreciate you teaching other people about it. I will put all of your information in the show links so that our friends can find you. And I just want to say thank you.
Thank you for having me. Thank you for what you're doing. And I just want to say that I see you as a mother, as a wife, as a physician. I see you as a hospitalist. I see the work that you do. I have mad respect for my colleagues, especially my hospitalist colleagues, because I know how y'all are treated in the hospital. But I just want you to know that I see you, and I thank you for the sacrifices that you've done and how you've made and how you have held together your family during this time. So hats off to you, to my hospitalist colleagues, to all of my mommy docs. Y'all always have a fan in me. Dr. Stephanie is always going to just root for you guys, always.
The love and respect is mutual. Dr. Stephanie Freeman, thank you so much for being who you are and doing what you do.
Love and kisses.
Bye, girl. See ya. Thank you. Handle that. Just give us a quick update on what does COVID look like in July of 2021?
COVID in July of 2021 looks just like COVID did in July of 2020. Looks just like COVID did in, February of 2020. What people do not realize is that there is no treatment for COVID. None. There is no treatment for the SARS-CoV-2 virus. Nothing works. And as you know, Dr. Alexis, being a hospitalist, we're on the same spectrum. You take care of these patients, they either get better or they get worse. If they get worse, you're sending them to me.
That's right.
I might send them back to you after they get better out of the ICU. Chances I don't. Because what we have to do, and what the public doesn't realize, is that when dealing with a respiratory virus for which there is no treatment, there is no effective antiviral, there's no effective medication, no effective drug that specifically targets and impacts the SARS-CoV-2 virus. So in situations like that, The only thing we can do is provide supportive care, which is symptom-based management and trying to mitigate the effects of ongoing infection and to support the body through the process. That's all we can do. That's all we can do. So we are no more closer to having improved clinical outcomes to COVID than we were prior. And the improved clinical outcomes that we're seeing is solely due to the critical care that we knew always worked. Supportive critical care, good medical care, good nursing care, good supportive care works in terms of doing what we can to support the body through this process, but there is no treatment for COVID per se, no treatment for the COVID virus. So therefore, to the general public, when physicians are terrified, it's for a good reason. Because if you get this virus and you have not been vaccinated, this virus is more likely to kill you, and there is very little we have to offer by the time you need our care.
Yeah. Yeah. So when they're getting to the point, 7, 8, 9, 10 days in, they've got mild symptoms, they're about a week in, and they're feeling short of breath enough to come to the hospital. At that point, the treatment is oxygen, nebulizers to open up the airway, steroids to decrease the inflammation. And we're trying meds. We're throwing, darts at the dartboard. But the science is the same as it's always been. And you're right, we don't have anything that we know reliably works. So prevention is where we were aiming our darts. We were aiming our darts at getting the good majority of the population to vaccinate so that we get to a point of herd immunity. And it just doesn't look like that's happening. From where I sit, the majority of patients, I think 88% of our patients who require oxygen therapy are unvaccinated. That's the number I got today.
Some numbers came out in Texas last week. And to go back to your first question about what does COVID look like in the ICUs right now, because there was a huge dip in COVID cases because the mitigation strategies worked, people were taking the vaccine, people were still wearing their masks, and the numbers dipped, then the number of patients hospitalized for COVID was decreasing. And it got to a low point. Now it started going back up. And what happens is it's just more burden on the healthcare system. So, we're headed to the point where we're going to be where we were back in January and February of this year, when, ICUs were completely full, opening up overflow ICUs, converting, closed units in the hospital to ICUs and step down units, and then toying at what's the magic number to open up these stadiums and convert these stadiums to hospitals. We're not there yet.
Right.
But if we get there, then there's a problem, because what the general public doesn't realize is that with the prior peaks, the prior surges, they happen kind of in piecemeal fashion at different parts of the country. Yeah. So you could pull, like, for me, for example, you could pull doctors like me who maybe weren't as busy, had some free time, not as tired. If we had some availability, we'll hop on a plane and go help out somewhere else.
Yeah, there were extra resources.
We had extra resources, and then you had extra resources in terms of the travel nurses and the travel pharmacists and travel respiratory therapists. But now for this surge, the numbers are going up everywhere. Maybe not as at the same rate, but they're going up everywhere. And so you're not going to have any expendable resources to send to the places that are harder hit, because the numbers are going up everywhere.
Yeah, the local places need their resources.
That is something that's terrifying.
Yeah. Yeah. Things are getting back to normal, in my opinion, probably a little bit prematurely. We're talking about going back to school, full day, no real necessarily chopping up the students into different cohorts. We're talking about whether or not people are going to be wearing masks. We obviously have mask mandates that are lifted all over the place. And as sick as the unvaccinated patients are, we are also seeing vaccinated patients who are sick enough to require hospitalization. So it's definitely less prevalent for vaccinated, and there's a lower incidence of people who are vaccinated getting an illness that's sick enough to require hospitalization, but that too is happening. So like we've been saying for a year and a half, the best things you can do are keep your distance, wear your mask, get your vax, right? Is there anything else?
That you're absolutely right. You are absolutely right. And it's astonishing to me because you know I travel for work.
Right.
I never stopped wearing masks. I
Uh-huh.
never stopped. I never stopped because I'm like, even though I'm vaccinated, I don't even want to get a mild form of COVID. So I never stopped wearing masks because I never saw where COVID ever went away. It never went away. People, it never went away.
Yeah.
I was still in places in which I was getting 1 and 2, you know, new COVID admissions to the ICU per week. And I was like, wow. So I never stopped wearing masks. And then when the CDC came out with this mask saying that if you're fully vaccinated, mask wearing is optional, then almost overnight, people stopped wearing masks. And I'm talking about like in hotels. Now,
Yeah.
of course, when you go to the airport, that's mandated federal law. You got to wear your mask. If you don't wear your mask on an airplane, they're kicking you off and they're arresting you. But I cannot tell you, I would be at all of these hotels and I would be the only guest wearing a mask. And I'm looking around like, I know everybody in here hasn't been vaccinated, but yet you're walking around without a mask. And then what was even scarier for me, knowing that kids under 12 can't get the vaccine, none of the children were wearing masks. And
Yeah.
this was at every single hotel I've stayed in since they lifted this mask mandate. And I was like, this is going to be bad. Going to the grocery store in some of these communities, nobody's wearing a mask. Now, in my neighborhood grocery store, everybody was wearing a mask, but out and about, these people aren't masking up. And I'm like, I know that everybody who is not wearing a mask is not vaccinated.
Yeah.
And I was like, this is going to be a problem.
What can you say to the people who, aside from, saying we see it, we're intubating people, people are dying in front of us, and kind of like the scare tactics of us, that they don't get to see what we see. Aside from that, from a scientific and realistic, real life perspective, what is it that people are afraid of with the vaccine, and what can you say to reassure people who are reluctant to get the vaccine?
Right. Thank you for asking. I just did a um, panel discussion about 6 weeks ago in one of my other groups about this, and we brought together women doctors, mainly Black women doctors who are experts in this, and we really kind of honed in on to what are some of the reasons that we in the Black community were having for vaccine hesitancy. And one of the biggest reasons was that people felt that the vaccine came too soon and they didn't really trust the science and the safety behind it. But when we're able to have conversations about how the science for this vaccine had been present for years, because it was the same science used to develop the potential vaccine for SARS-CoV, that this is not new technology. The technology has been there, the science has been there, but that with every available resource in the world aimed toward this singular focus of getting this vaccine, that's why the vaccine was able to be produced in record time. So a lot of people just were afraid of the vaccine, afraid of the unknown, afraid of what appeared to be a process that happened too soon in their opinion. So what I try to do when I have these discussions is to ask people, why are they afraid? And when you kind of get to the why and can kind of just explain to them what the reasoning is, then a lot of times they'll take, another approach. Also, I think that a lot of people may just be resistant to the fact of somebody else telling them what they should do. And we, you know, now it's to the point where we just have to continue to respect that and hopefully provide enough information that people will make the best decision. But I think what we as physicians can continue to do is just to engage in dialogue and understand the real reasons behind vaccine hesitancy. A lot of people were still afraid of the side effects, and understandably so. It seemed like every other week Johnson and Johnson was coming out with
Yeah,
another, side effect adverse event.
right.
Um, so we have to be understanding of that and just understanding the reasons behind vaccine hesitancy, and just to continue to discuss the facts.
We always talk about autonomy, especially in the ICU with respect to patients' wishes for their body. That's one of the things that we base our medical decision making on is what does the patient want? You can give them all the treatment options in the world that exist. If they don't want them, it's their right as an autonomous human to decide what is best for their body. And so what I say to the patients who are, after we discuss the facts about the vaccine and the vaccine science, and after I try to use scare tactics, and after I try to give some real numbers and real reliable information about what the vaccine is and isn't, like you said, the last thing I say is I have to respect your autonomy to not receive the vaccine. That's not my job to tell you that you have to take the vaccine, because you still have free will and you can still make decisions for your own body. However, if you are not going to be vaccinated, then at the very least, please continue to wear your mask, so that if you are a carrier, or that if you are, in communication or in contact with a person who is vulnerable or susceptible, that you still care about other people around you, and that you are doing some part to help us be able to continue working towards treating people and taking care of people. And that's, I think, the least you can do if you don't want to get vaccinated, and we can't tell you that you have to, that you can